So this is great, and it sounds like you accomplished a great deal during your presidential year and your years as an officer. How long have you been a member of the Medical Society, and what kinds of things?
Well, it's coming closer to 30 years now.
Yeah, wow.
I'm giving my age up here so people can actually calculate.
So late 80s.
Yep. And I came to Massachusetts back in 1984. I trained at Mass General Hospital and became very familiar as a resident with, I came to Massachusetts in 1981.
Okay.
And as an internal medicine resident. And that's when I became involved with the Mass Medical Society. Not consistently until I actually finished my residency program, and then I was more consistent in the Medical Society after going into private practice at South Shore Hospital.
And were you on committees before you became
Yes.
an officer?
Yes.
What sort of things were you dabbling in?
So the reason why I got involved with the Medical Society is that I had this idea about going into schools and teaching students the dangers and hazards of cigarette smoking. So I started doing this on my own in the southeast region. I would get the doctors to sign up every year on a list. Oh, okay, you're going to go to Abigail Adams, you're going to go to Hull, and it was fun. And the doctors loved it because it was like they were doing something that they could donate an hour of time, take very little preparation, and so we started. It is now in its 22nd year, and we got more sophisticated as time went on. As time went on, we began to involve the school nurses, and we would have pig lungs. We'd do some really innovative things, and the kids would come up and they'd touch the pig lungs and they'd go, ooh. You know, we'd have one pig lung that smoked and one pig lung that didn't. But it really it was a wonderful program. And Bart Salino and Jim Devon encouraged me to get involved with the Medical Society. He says, you know, both of them said, well, listen, if you're doing this, you can engage the Medical Society. They'd like to be engaged in going to outreach, going into the community.
Sure.
And so that was a major reason why I joined the Medical Society.
Neat.
And it was wonderful because now I had my whole district involved.
Sure.
And not just the doctors from South Shore hospitals. We had doctors from Quincy hospitals. We had physicians who were from Boston who would come out. And so that's when I first got involved. So I got involved with the Norfolk South District, and then I was on the executive committee, and then I went up the ranks to become president of the Southeast Caucus. And I was so encouraged by my mentors who really wanted to see me involved to the level that they saw me with some leadership skill sets.
And this is really interesting because you, at the beginning, didn't so much join the Medical Society to participate in what they were doing, so much as you joined the Medical Society to magnify the effect of what you were doing.
Right.
So it was.
Now I was a member, but I wasn't a member on the executive committee. So I was just a member at large. But to get more engaged with the executive committee, the idea of, wow, I could actually be able to do a whole lot more working with a group of physicians than by myself.
Sure. How great is that? So let's talk a little bit about your practice. Now, you've got pretty broad training.
Yes. So I trained at Mass General in internal medicine.
Yeah.
I went in private practice for probably around a year. And then I went back into training in anesthesia. I did an anesthesia residency, my second residency. And then I did a critical care fellowship. And then after I finished the critical care fellowship, I did a cardiovascular anesthesiology fellowship at Tufts.
Yeah.
And so I had 2 fellowships, 2 trainings, and afterwards I wanted to do intensive care medicine and anesthesia.
Yeah.
So I've had an opportunity to practice in a multiplicity of settings, not just the academics. I was on staff at Tufts. In the community, when I was in private practice internal medicine, I was down in Central Falls, Rhode Island, which is a very different community than Boston. And then now I'm practicing and have been practicing in South Shore Hospital for a very long time. And South Shore Hospital has a diversity of patients, first of all. Diversity in terms of socioeconomic status. So we have people who are from Hull and Weymouth. We have people who are from Duxbury and Cohasset. So we have such a wide variety of patients with varied disease processes. And I can say in 1993, okay, this is an example of the type of patients that we would see. There was, I think it was about 9 cases of tetanus in the country. One was at South Shore Hospital. And it was just amazing. A lady who had been out in her rose garden. We at South Shore Hospital see everything. And so it was a great place to practice. And I really like the idea of walking into a patient's room and being able to look the patient in the eye and say, I'm going to help you today. How am I going to help you today? And not just to say, okay, go in. And I'm hoping that the students, the residents that shadow me, catch that vision of you may be the only person in that patient's room that that patient feels is genuinely supporting them. Because if they catch that at an early age, it will continue. The value of that is so important, and it should be utmost the goal of every physician when they walk into the patient's room to say, how am I helping you today?
That's, that's wonderful. And it's interesting to listen to you because you, with these fellowships and this very, very technical training that involved a lot of very specific science and minutia, you haven't lost sight of the big picture and why you're there. And that's really admirable, and it's a wonderful perspective to impart to students. So what kind of conditions do you treat these days?
So I'll give you an example of a string of patients that I had, and I also work at an LTAC as well. And recently I had a string of patients who had Guillain-Barré, ALS, and a variant of a antimitochondrial illness. The patients were quadriparetic, and they were paralyzed from neck down. And so 3 of the patients came in. They were all Guillain-Barré syndrome, and they were paralyzed from neck down. And they were sent to the LTAC to wean off the respirator. Now, mind you, their head's working fine. They're thinking fine, but they are not able to do what they would normally do. And so when you walk into their rooms, you gotta instill some hope when they're completely listless and they cannot move. And I said, okay, here you go. Can you make a difference with the words that come out of your mouth? Because right now, there's no action in their muscles that tells them that they're going to be better.
Sure.
And my goal was a little bit incremental weaning. Even if I just said, we went down a breath for a couple of hours on the ventilator. Or if I said, we're going to have you sit up. We're going to see if your diaphragm will work better. We're going to see if we can get you to take over a little, maybe just a few percentage points off the oxygen, take it down, or, and so every day I look for something positive to say to them. And lo and behold, 2 of the patients, one with the Guillain-Barré, said, because I let his cuff down to allow him to talk, he says, I feel some tingling. And it was interesting because the other patient had felt some tingling. And this is like long into the course. We're talking about 8 to 10 weeks in. And this is like, okay, is anything going to happen in terms of recovery? And these diseases, the tincture of time. I'm happy to say that all 3 of the patients began to have movement, and 2 of them actually began to have more progressive movement to the point where they have been weaned off the ventilator.
Wow.
And it really taught me. So being in an acute care hospital, sometimes we package them up to go to a SNF or to an LTAC, a long-term acute care hospital, and we just say, okay, that's it. You kind of like psychologically you get it adjusted to the fact that they're gone now, but you don't see the improvement that actually occurs over a longer period of time. And I know the doctors who work at LTACs, they know that story. Because when you see them improve, there is nothing more gratifying than knowing that you were in that right place at that right time.
Sure.
To see the patient actually improve and to look at the satisfaction and the gratitude on families' faces in the room. And to me, you know, we always are excited about the acute care process, but I get even more excited when I see families who have patiently been waiting. They've been in and out of those rooms, day in and day out, calling. They go to work. They might sneak a FaceTime. And then all of a sudden one day, they get that news.
Yeah.
You know, they get that FaceTime, and they see their loved one.
Yeah.
Guess what? I'm off, and it was so nice. One of my patients, he actually sent me a video of him, and it was one of the patients, and he was doing like this, and it was just so rewarding, and it was like no one could have said anything better to me that day. That day, it was the best thing I ever heard.
That's great. So during the decades that you've been in practice, the treatments that you've been able to offer patients have changed. What stands out in your mind as some of the bigger advances that have affected your practice?
Well, I'll speak from three standpoints. One is the progress in literature and how it has dictated how we practice in sepsis management.
Okay.
Sepsis management has been totally turned on its head, and it keeps turning. We were early on giving patients norepinephrine, and we would see them on so much norepinephrine that they would auto-amputate their digits, and we didn't understand the importance back then of giving fluid because they had distributive shock. And everyone was talking about, you know, just pouring on the pressors. Come fast forward, you know, 15, 20 years later, we've got Manny Rivers coming out with early goal-directed therapy with fluid management. In between there, we had this big pull to use Zygris, this gorilla-silin drug that cost over $3,000. And then we had a study that says, nay, 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 nay. And it has no evidence, and we stopped using that. You know, medicine said, this is not a good thing. We have no evidence for what we're doing. Same thing with sepsis management with PA lines, pulmonary artery catheters. We used to put so many pulmonary artery catheters in, it was ridiculous. Then as the studies evolved, do patients do better? Does the mortality change? The answer was no with sepsis management. So we don't put in PA catheters like we used to, even in the face of renal failure. So that's different in terms of how we line patients up, how we treat them with fluid, and now getting to the point where we changed the mortality rate by how quick we give the antibiotics. You know, we used to say, give it within 12 hours, give it within 6 hours. We're trying to drop antibiotics within an hour, you know? And the literature has shown that the quicker you get the antibiotics and the more targeted the antibiotics are, the better the patient does, okay? Sepsis management, ARDS management, ventilator management, putting patients on ventilators. We've gone from the place of high tidal volumes, giving big breaths and low PEEP, to giving smaller tidal volumes and bigger PEEP, trying to prevent ventilator-associated lung injury. It's been incredible. The field of sepsis and adult respiratory distress syndrome, all of those things in terms of all of the intervention, the invasive procedures that we used to use, I mean specifically the PA line, all of that has been transformed. And it's been transformed for the betterment of patients, okay? That's one piece. The second piece is the whole issue around access. I remember it was probably the mid-90s of taking care of a lady who came in and she was short of breath. And she obviously had stridor. and she had a tumor. She had a laryngeal tumor, and she had an audible breath, a voice that was so slight. And she said she had held off seeing a doctor. She was 62 years old, worked at a cleaner's on the South Shore. She had held off seeing a doctor until she qualified for Medicare.
Mm-hmm. So access has improved, the implementation of science has improved.
Yes, and that young lady wound up having to have a tracheolaryngectomy when she could have had earlier intervention. She may not have needed that.
Sure.
But she held off making a decision to seek a doctor because she did not have health care coverage.
Right.
That was back in the day,
mm-hmm.
before universal coverage.
Mm-hmm.
And then I would say the transformation that has not been quite as good is that I see the segment of society where you have access to health care, but when you get into even ivory towers, there's differentiation of your outcome based on a number of things. First, what provider you get.
Mm-hmm.
So we've done that study. High volume providers, better outcomes. High volume specialized hospital, better outcomes.
Mm-hmm.
So that you can make a decision to go to the healthcare center and still have a bad outcome. And it has a lot to do with who you wind up seeing once you get there.
Mm-hmm.
And that's the bad story, that we haven't gotten our arms around that piece. The other piece is immigrants and how we care for immigrants. Mm-hmm. Not realizing that the immigrants are such a valuable part of our society in terms of what they do outside.
Sure.
That when we don't care for them, there's that segment of our society that is impaired for a number of reasons. And so, although we haven't been able in Massachusetts to address that issue fully, going forward, hopefully we'll be able to address that.
And you're bringing up the fact that as we have this conversation, the issues regarding immigration to this country are high profile, but really not too much in the way of solutions. And immigrants themselves feel threatened, and this is affecting, among other things, mm-hmm. their accessing health care.
Right, right.
Wow. So those are good insights.